Hi, everyone. On today's podcast, we're going to talk about alternatives to antibiotics for Group B Strep, as well as answer some frequently asked questions about this hot topic. Welcome to the Evidence-Based Birth Podcast. My name is Rebecca Decker, and I'm a nurse with my PhD and the founder of Evidence-Based Birth. Join me each week as we work together to get evidence-based information into the hands of families and professionals around the world. As a reminder, this information is not medical advice. See ebirth.com/disclaimer for more details. Hi, everyone, and welcome to today's episode of the Evidence-Based Birth Podcast. My name is Dr. Rebecca Decker, pronouns she, her, and I'll be your teacher for today's episode. Today, I'm so excited to bring you more evidence-based information to you about Group B Strep during pregnancy. One quick content note before we get started. On today's episode about Group B Strep, we will discuss stillbirth, infant death, preterm birth, critical illness of newborns, and racial disparities in positive GBS tests and GBS disease in newborns. This is the second evidence-based birth podcast where we're focusing on Group B Strep, and we're doing this to celebrate the update to our signature article on Group B Strep, which is published at our blog located at ebirth.com/groupbstrep. Our original article on Group B Strep was published for the first time in 2014 and last updated in 2017. So today we're sharing with you more research from the 2023 update on this topic. This is part 2 of a 2-part series. In part 1, which is episode 254, we talked about the evidence on GBS during pregnancy, how the microbiome works in the body, the evidence on testing for GBS, and the evidence on antibiotics, including the pros and cons of receiving antibiotics during labor for GBS, as well as options for people who have allergies to penicillin. Today, in part 2, we're going to switch gears and talk about the evidence on alternative treatments for Group B Strep and answer some of your questions about GBS. Before we get started, I have to remind you all that GBS is a controversial topic, and ever since I first started publishing on GBS in 2014, I learned that some people can be really angry when I talk about Group B Strep and the research on this topic. So if at any point you start to feel your heart rate go up, your breathing shift, or you feel intensely emotional, please use this as a sign to turn inward to process these emotions and not outward to lash out at me or at my team at EBB. Unfortunately, when part 1 of this episode came out, we did receive some really rude, just downright mean emails to our customer service team. And that is just not okay. If you want to disagree with someone, that's fine. But our role here is to provide information, not judgment, and we're not here to get in fights with people, and we don't want to be attacked for simply talking about the research on a subject. So I'm asking you to please try to separate the information here from your emotional response. And we have a whole episode about how to disagree on difficult birth topics respectfully. You can find that at EBB 87. Also, as a reminder, there's a lot of misinformation online about GBS and about alternatives to antibiotics for GBS. So we are coming to share with you info on this podcast that comes from 9 years of reading the research on this topic, and I hope it's useful for all of you. Also, my team and I will not be answering email questions about this topic. We receive hundreds of emails per day, hundreds of messages and comments in social media as well. And so we have a policy that our research team only answers questions that are asked of us specifically inside the Ask the Research Team forum, which is inside the EBB Pro membership so that our researchers can get paid for the work that they do. You can join that membership by going to ebirth.com/membership. In terms of free resources, we do have a free 1-page handout on the evidence on GBS that you can download from our website to use in your informed decision-making. Just go to ebirth.com/groupbstrep, that's all one word, Group B Strep, to access the entire full text of the signature article on Group B Strep, along with the free 1-page handout. So today in part 2, we are going to cover the other risk factor approach: chlorhexidine or hibiclins, garlic, vaccines, probiotics, topical use of human milk. I'm going to answer some of your questions. I'll go over the guidelines from 3 different countries And I'll share with you our bottom line for what we think about the research on Group B Strep, antibiotics, and alternatives. Are you ready to get started? All right, let's go. First, let's talk about some alternatives to antibiotics for Group B Strep. As I talked about in part one alternative to the universal screen and treat approach is the other risk factor approach. This is when you receive antibiotics based on other risk factors, such as having a fever during labor or your water being broken for more than 18 hours. And that's in contrast to the universal screening approach where you're tested for GBS and given antibiotics if you test positive. Now, researchers have found that the percentage of birthing people who receive antibiotics is roughly the same whether you are using the universal screening approach or the other risk factor approach. They're somewhat high in most developed countries. Rates of antibiotic use during labor are about 30%, regardless of which strategy is used. However, as I already talked about in part one, there's a lot of research from randomized trials, but mostly large observational studies showing that the universal screening approach is more effective than giving antibiotics based on other risk factors. And that makes sense because the main risk factor for a newborn experiencing early GBS disease, a serious illness, is when their birthing person is a carrier of Group B Strep. And about 60% of newborns who have early GBS disease have no other risk factors other than the fact that their birthing person was a carrier of GBS. Now, some countries have started to shift their policies. Countries that use the other risk factor approach are now trying to incorporate GBS into their approach, even though we don't have any research on that yet. For example, in some places, birthing people might be treated with antibiotics during labor if they are GBS positive plus they have a fever or plus they have prolonged rupture of membranes. But in most cases of newborns having early GBS disease, again, the only risk factor is that the birthing person tests positive for GBS. So it's quite possible that the combination strategy of requiring a GBS test plus one other risk factor will not prevent most cases of early GBS disease in newborns. But we do know that it works somewhat. So overall, when you're looking at large populations in places where there's a policy of universally screening and people for GBS and treating them with antibiotics during labor, the overall rates of newborns having early GBS disease are 0.2 cases per 1,000 births. And in countries where the other risk factor approach is used, the overall rates of early GBS disease in newborns are about 0.5 per 1,000. So it obviously works somewhat. It's just not going to be as effective as the screen and treat approach. Also, you have to keep in mind that if you use the other risk factor approach, still about 30% of the time, you're going to have someone be exposed to IV antibiotics during labor. And in some of those cases, you're exposing someone to IV antibiotics when they didn't need to be exposed. They might have a fever, but maybe it's from their epidural, or they have prolonged rupture of membranes, but they have no signs of infection. So you're giving people antibiotics targeted at preventing early GBS disease without knowing whether or not they are a carrier of GBS. But I do look forward to hopefully seeing more research the next time we do an update on a more combination approach, which I have seen some countries start implementing. Another alternative you hear people talk about is chlorhexidine, sometimes called Hibiclens. Chlorhexidine is a topical disinfectant that kills bacteria on content. It binds easily to the skin and to the mucous membranes. And in the vagina, the anti-GBS effect of chlorhexidine lasts from 3 to 6 hours. So it can suppress GBS in the vagina for 3 to 6 hours. It has been shown to be safe. It's fairly easy to administer and it's cheap. Hibiclens is a brand formulation that includes chlorhexidine, and most research studies only examine chlorhexidine. But in some countries like the US, many providers can only access the brand Hibiclens. Sometimes outside of labor and delivery, you might see this as that kind of brownish liquid that is used to sterilize the skin before you have a procedure. So in a Cochrane review that was last updated in 2014 by Olsen et al., researchers combined results from 4 randomized trials that compared vaginal chlorhexidine wash versus a placebo wash or no treatment. And they looked at the health outcomes of 1,125 infants born to parents who were GBS positive. Unfortunately, the evidence from these studies was judged to be of very low quality from the Cochrane reviewers, and they even had to remove a fifth study that was included in previous versions of the Cochrane review because it did not include people with GBS. And they also had to correct a data mistake from the previous version. So when they had this updated review in 2014, they found that chlorhexidine does not lower the baby's risk of becoming a carrier of GBS, and it does not lower their risk of early GBS disease. There were 0 cases of infant deaths from GBS in either group, and the chlorhexidine group had higher rates of people complaining of stinging and irritation in the vagina. The researchers said we still need large, high-quality, randomized controlled trials to test chlorhexidine to see if it can prevent early GBS disease, but the research that we have so far is not very promising. However, you don't want to write off chlorhexidine completely because it could be beneficial for pregnant people who live in low-resource areas where access to antibiotics is limited. So there was one review of the literature published quite a while ago by Goldenberg et al., and they looked at studies from Egypt and Malawi where researchers were putting chlorhexidine in the vagina every 4 hours during labor, and then they also used wipes of chlorhexidine on the babies after birth. Now, these were observational studies. They were not randomized controlled trials where the researchers were following hospitals over a long period of not using chlorhexidine, then using chlorhexidine, and then stopping the use of chlorhexidine. And in both the studies, they found that when chlorhexidine was used to wipe the vagina and wipe all over the newborn after it was born, there were decreases in newborn hospital admissions, newborn admissions for blood infections, and newborn admissions and deaths due to overall infections. So is chlorhexidine effective? Well, randomized controlled trials that took place in high-resource countries where they applied it to the vagina during labor found that it does not lower the baby's risk of becoming a GBS carrier themselves or experiencing early GBS disease. However, we do have this research that in low-resource areas, using the chlorhexidine wipes on the vagina and on the newborn can lower sepsis rates in general. And I also found another study published by Islam et al. In 2016 where they proposed that you could apply chlorhexidine to the umbilical cord stump after the baby is born, which might help prevent GBS-related blood infections. So chlorhexidine might be better than nothing, but it does cause stinging and irritation, and it does not prevent the rise of GBS in the baby's blood and amniotic fluid. It would have to be given before the birthing person's water breaks and repeated before the effect wears off. In contrast, when you compare that to IV antibiotics, which is the standard, IV antibiotics, when given to the birthing person, get into the blood supply of both the birthing person and the fetus in non-toxic levels, and that can prevent or stop GBS from growing in the baby's body. Garlic is another interesting alternative that sometimes you hear people propose. Garlic does have natural antibacterial properties, and some websites recommend putting garlic cloves in the vagina to eliminate GBS before you're tested for GBS. However, we can only find 2 laboratory-based studies on the subject, so nothing done in humans yet. But in the lab, one group of researchers put garlic extract and GBS in a petri dish together, and they found that the garlic was able to kill the GBS in about 3 hours. And then another group of researchers tested compounds from garlic and found that 4 of the compounds that can be isolated in garlic can inhibit the growth of GBS in a petri dish. So although garlic may seem like a promising natural treatment, it's important to understand that this treatment has never been tested in humans. Some people cite a letter to the editor that was written by Cohane in 2009 as being a research study, but it is not a research study. And if garlic has any anti-GBS effect, it's likely only temporary. This is because back in the 1970s, when researchers tried giving people with GBS penicillin during pregnancy instead of during labor, they found that it temporarily worked to lower levels of GBS, but levels almost always went back up by the time you went into labor. So if you're temporarily using the garlic during pregnancy, this could help you get a negative test result, but the effect would wear off very quickly and the GBS can grow back. And there's no other research on the possible benefits and risks of short-term or long-term garlic use in the vagina. It's possible that garlic insertion in the vagina could have unexpected side effects, such as premature rupture of membranes, or it could increase other bacteria due to the destruction of good bacteria. So until we have more research on the potential benefits and harms, there's a lot of unknowns related to putting garlic in your vagina. Another future alternative is going to be vaccines. And I know people get really triggered when we talk about vaccines, so again, refer to my trigger warning at the beginning of this episode. Here's the thing. Researchers have been working to develop a GBS vaccine for multiple reasons. Number one, giving IV antibiotics during labor does not prevent GBS infections 100% of the time. There can still be some breakthrough cases. Number two, giving antibiotics during labor has side effects, and it can negatively impact your microbiome and the microbiome of the baby. Third, giving antibiotics during labor does not prevent other GBS diseases, such as preterm labor, stillbirth, or late onset GBS disease in newborns. And fourth, pregnant people in low-resource parts of the world have difficulty accessing GBS testing as well as IV antibiotics during labor, or even medical help if their baby is born sick. If you go back to part 1, we talk about how this is a huge problem and how GBS is a leading cause of infant death and stillbirths around low-resource parts of the world. There was a bunch of research that came out in 2017 where they were combining studies and meta-analyses from all over the globe. And in one meta-analysis published by Seal et al., they calculated the numbers and they predict that if a GBS vaccine worked 80% of the time, and if it was given to just over half of the pregnant people in the world each year, we could prevent 23,000 stillbirths, 127,000 cases of early GBS disease in newborns, and prevent 37,000 infant deaths each year. They also calculated that vaccinating half of all pregnant people worldwide would be more effective at preventing disease and death than using GBS screening and providing labor antibiotics to more than half of the pregnant people in the world. Because of this, there has been a lot of work towards developing a vaccine for GBS. There have been at least 5 pharmaceutical companies involved in GBS vaccine development. Most of the vaccines are in very early phases of development, including discovery, preclinical, and phase 1 safety testing. But there is a vaccine candidate by Novartis and GlaxoSmithKline, which acquired Novartis, and that vaccine has completed phase 2 safety in pregnant people. And their phase 2 research was published in 2020 by Swami et al., and they did a randomized placebo-controlled safety study in the United States. The researchers recruited healthy pregnant people who were between 24 and 34 weeks of pregnancy. All of them received standard GBS testing in the 3rd trimester, and they all received antibiotics during labor if they were GBS positive, and about 37% of the sample was positive for GBS. So out of the 75 participants, 49 received 1 dose of the GBS vaccine and 26 received a placebo shot. The researchers followed the participants through the rest of pregnancy, through birth, and up to 6 months postpartum. They measured the antibody response by collecting blood samples from pregnant people on day 1 and day 31 after vaccination. They also collected blood samples the day of giving birth and on postpartum days 42 and 90. And then they measured antibody response in the infants by collecting samples of cord blood at birth and blood samples from the infant on days 42 and 90 of life. The most common side effects were injection site pain. It was painful in 50% of the vaccine group, 31% of the placebo group, and fatigue. Fatigue rates were 38% of the vaccine group and 23% of the placebo group. They found 0 vaccine-related serious adverse events in the study and no differences in pregnancy or birth outcomes between the 2 groups. At 6 months of age, they performed developmental assessments on the infants and found no differences between groups with cognitive, communication, fine motor, or gross motor skills. But what they did find differences in was the antibody response. So on day 31, after receiving the vaccine, the pregnant people in the vaccine group had an immune response that was 13 to 23 times higher than the placebo group. And these antibodies transferred to the fetus through the placenta. And antibodies to Group B Strep were detected in the infant's blood from birth through 39 days of follow-up. And the vaccinated group also had high levels of antibodies to GBS in human milk samples. So right now, public health experts around the world are optimistic about the potentially positive impact that GBS vaccines could have around the world. As researchers said, quote, "An effective maternal GBS vaccine offers an all-encompassing approach to reducing GBS disease, and as vaccine strategies can achieve high coverage even in the most challenging settings, it is likely to be a more equitable intervention than intrapartum antibiotic prophylaxis. Maternal GBS vaccination has the potential to reduce this disease burden worldwide within the next generation and including the poorest families," end quote. Another alternative that people are always asking about is probiotics. And I was excited to be able to update the research section on probiotics since more has come out since our last GBS article update. In theory, taking probiotics in pregnancy should help lower the odds that you will test positive for GBS in the third trimester. And this is because beneficial bacteria such as lactobacillus make the vagina environment more acidic, which inhibits growth of GBS. So in a meta-analysis published in 2022, Hansen et al. Reviewed 6 studies that examined whether oral probiotics, primarily containing lactobacillus, can lower GBS rates in pregnancy. The authors determined that probiotics had a moderate effect on reducing the chance of testing positive for GBS. However, 5 of the 6 studies in this analysis were at high risk for bias, meaning that we can't have confidence in their results. For example, in one study, pregnant people were put into probiotic and control groups based on whether they were sick or not and whether they wanted to take probiotics or not. So you had 2 very different groups. And they didn't even baseline check to see if they had GBS to begin with. Another study also did not measure GBS before the probiotics were started, and it had to be shut down early because the probiotics all expired. Can you imagine doing a trial where you're giving people expired products? Because of all of these quality problems with the studies, Hansen et al. Then went to publish their own randomized trial in 2023. And this was a really high quality study that was supposed to address all of the weaknesses in the previous research. So this randomized trial included these strategies. First, they enrolled 109 healthy pregnant people with the knowledge that they needed at least 80 people in the study to find a difference between probiotic and placebo results. And then they were randomly assigned to either receive highly potent capsules with lactobacillus and other probiotics or placebo capsules. Both groups started the pills at 28 weeks of pregnancy and continued until labor started. They also did baseline collection of swabs to see if they had GBS at 28 weeks and then again at 36 weeks. The participants in the study staff were not allowed to know which group each person was in, and the probiotic and the placebo pills were identical in appearance and taste. So this is what we call a true double-blind study. They even measured adherence with use of these special pill bottles that track how often the pill bottle is open. The probiotics were kept refrigerated. They did frequent potency testing on the probiotics that were being used in the study to make sure that they were actually active probiotics. The participants got daily reminders to take their pills, and they measured gastrointestinal symptoms at baseline, 28 weeks, and 38 weeks. They also measured if people were eating yogurt, if they were sexually active, if they were using vaginal cleansing practices. So they were tracking all of these things so that they could account for anything that could disrupt the study results. In the end, 83 people completed the entire study protocol, and the results showed that the probiotic group had fewer gastrointestinal symptoms at 36 weeks compared to the placebo group. So it helped with stomach and GI symptoms. However, there was no difference in rates of testing positive for GBS when they were tested at 36 weeks. The pill bottle caps showed that both groups took their assigned pills only about 51 to 60% of the time. So people were not really good at remembering to take them, even when they received frequent reminders. But there were no adverse health outcomes in either group. And as I said, the probiotic group had fewer gastrointestinal symptoms. So basically, the research on taking probiotics to lower the chances that you'll test positive for GBS is not very compelling. But no study has found side effects related to taking probiotics and in terms of GBS prevention during labor. And at least 3 studies have found that when you take oral probiotics, that it reduces your distressing GI symptoms during pregnancy. So although taking oral probiotics might not lower your chances of testing positive for GBS, it doesn't seem to hurt, and it might help with other symptoms of pregnancy. Another new section of our article and a new alternative that we added to our article is that of topical use of human milk. So researchers have just recently begun to explore the possibility of applying human milk or breast milk onto the vagina to suppress GBS. This is because one of the main ingredients in human milk is oligosaccharides, also known as human milk oligosaccharides or HMOs. This key component of human milk was first identified in the 1930s when scientists were trying to understand why infants were surviving more when they were fed with human milk rather than formula based on cow's milk. So we now know that there are more than 100 types of human milk oligosaccharides, and they make up about 8 to 20% of each ounce. These human milk oligosaccharides, or HMOs, are more complex than simple sugars, but they're less complex than starches. Scientists are still trying to understand the effects of the human milk oligosaccharides, but so far they have been shown to act as prebiotics. So they feed the good bacteria in the gut. They block bad bacteria from finding a home in the gut. They positively impact the immune system. They provide nutrients for brain development, and there's other benefits as well. In contrast, farm animals such as cows and goats produce very few oligosaccharides and at levels that are 100 to 1,000 times less than what is found in human milk. And there are no other natural sources where human milk oligosaccharides are found. So to mimic their effects, non-HMOs are currently synthesized in factories and added to some infant formulas. And there has been some research on the benefits of this, but we still need more long-term research on manufacturing these compounds that mimic it and put it in formula. Now, in part 1 of this article in the earlier episode, I talked about how when an infant is fed with human milk, this lessens the negative effect of antibiotics on the newborn microbiome. However, we now have research suggesting that topical use of HMOs could also be a potential pathway for preventing GBS during pregnancy. So in 2017, 3 different research teams found that human milk oligosaccharides could inhibit the growth of GBS when they put it in a petri dish in a lab. This was published by Lyon and Doron in 2022. Then in 2022, researchers also found that if they topically applied human milk oligosaccharides to the vaginas of laboratory mice, they found that it could inhibit GBS and it did not disturb the rest of the vaginal microbiome. Unfortunately, we do not have any human subject research on this topic yet, but I think it will be interesting to see how this field will evolve and what kinds of studies might be published in the coming years. I want to briefly mention colloidal silver. There's a few websites that mention colloidal silver as a remedy for preventing GBS infection. And although silver has antibacterial properties, no research studies have ever looked at the safety of colloidal silver during pregnancy. And in 1999, the Federal Drug Administration in the US cautioned that colloidal silver is not safe or effective for any condition. And there have been other researchers that have documented serious toxicity and health risks of taking colloidal silver. Unfortunately, there's a lot of online misinformation on this topic. I did find a peer-reviewed article on colloidal silver with facts for consumers at Healthline, and we will link to that in the show notes. So that's about it for the evidence on alternatives. Now I'm going to shift to answering some of your questions about GBS and about alternatives and about testing. We've had a lot of people ask if they can swab themselves for Group B Strep. Can they collect the sample themselves? Maybe, in one pregnancy, a provider let you do it, and the next pregnancy, you have a different provider, and they refuse to let you swab yourself. So we looked at the research on this, and there have been at least 2 studies showing that the results of a culture test after doing the swab yourself can be nearly as accurate as letting a healthcare worker collect the swab. And as a result, the guidelines in the United States mention that pregnant people can collect their own specimens after receiving instruction on how to do it. So, for example, in one study on this topic, they were looking at GBS testing in a diverse group of people in Canada. Most of the pregnant people that they approached agreed to be in the study, showing that it's acceptable to patients to swab their own vagina and rectum. They were given written instructions and a diagram showing how the swab was done. And in the end, the culture tests from swabs collected by healthcare workers was slightly more sensitive than the ones collected by patients themselves, 97% versus 88%. But they said that the results were acceptable in both groups. A similar study was carried out in Ireland, also finding that it was slightly more accurate for the clinicians to collect, but the results were still acceptable when the patients collected it. But then there was also one study out of Hong Kong that found that pregnant people there may be more hesitant to collect their own sample, leading to less accurate results. So you have to remember when you're collecting the swab, we talked about this in part 1, but the cotton tip has to go just a little ways into the vagina, and it does have to enter through the anal sphincter just a tiny bit as well. And if it's not entered through the anal sphincter, then your results are not going to be as accurate because you're looking to see if GBS is in the intestinal tract, if it is also in the vagina. And by swabbing both, you're more likely to get an accurate picture of whether someone is a carrier of GBS. So in the study in Hong Kong, researchers found that the healthcare collected swabs were accurate 98% of the time, but the ones that the patients collected themselves were accurate only 61% of the time. And so they concluded that cultural factors may make some people less inclined to perform an accurate self-screening test. So to sum up the answer to this question, self-swabbing can be a good option if you want to collect the sample yourself and you're willing to do it, but other people may prefer or be more comfortable with a healthcare worker collecting the sample for them. Another question we get a lot is, why do I have to be tested at 36 or 37 weeks? Could I just be tested closer to when I go into labor? Could I be tested during labor? Well, processing a GBS culture takes at least 1 to 2 days, which means the sample has to be collected before labor begins. And that's why it's typically collected before you reach term or right when you reach term, so that, you don't go into labor right after you reach term and you don't have results yet. Now, because GBS levels can increase, they might be undetectable at first, way up high in your intestines, but they might increase and then populate the vagina and rectum. On the other hand, GBS levels can decrease. They can be detectable at first, but then retreat farther back into the intestines and no longer populate the birth canal. This means someone who tests positive at 36 weeks might not be positive during labor at 40 weeks and vice versa. So the theory is if we had a rapid test that was reliable, then we could test people during labor and we'd only be identifying and treating those whose birth canal actually has GBS while giving birth. So in theory, this would help, have fewer missed cases of GBS and less usage of unnecessary antibiotics during labor. So when I first published this article on GBS in 2014, there was a lot of attention on rapid tests. And I was thinking, wow, this might become the change in practice. But since then, the research is pretty clear that I think rapid tests are unlikely to become common. That's because when clinicians use the rapid tests in real-life scenarios, as opposed to in a clinical trial where they're strictly controlling every step of the process, rapid GBS tests just are not as accurate as doing a culture test. And even the most rapid tests still take 1.5 to 2 hours to process at minimum, which is not helpful if labor is moving quickly. And there's a lot of conflicting research on whether rapid tests can lower the rate of unnecessary antibiotics. Also, rapid tests don't help people who have allergies to penicillin. So if you have an allergy to penicillin and you need an alternative antibiotic, they really need the culture test so that they can see like which antibiotics will work on your specific strain of GBS. Also, relying on a rapid test strategy means you need a hospital laboratory that is open and running 24 hours a day, which is not available in some hospitals. However, it might be a good option to have a rapid test if you're in preterm labor, or if you were not tested or you didn't get your test results back yet, and then you go into labor. And because of this, some hospitals are starting to carry a small supply of rapid tests, but I don't foresee them being very common. Another question we get is about, the antibiotics causing medicalization of the birth, and people don't want to be hooked up to the IV continuously. So you do not necessarily have to be hooked up continuously. If you choose to receive the antibiotics during labor, you will have an IV placed, but it takes a limited amount of time for the antibiotics to run in through the tubing. Each antibiotic is slightly different, but penicillin and ampicillin are typically infused over 15 minutes and given every 4 hours during labor, which for many people would only be once or twice. So you could be unhooked from the IV for 3 hours and 45 minutes and then hooked back up for the 15 minutes it takes to deliver the medication. If you have a penicillin allergy, the most common alternative is cefazolin, which is usually infused over 30 minutes and it's given every 8 hours. So then you could have 7.5 hours that you could ask to be unplugged from the IV and left with a saline lock. Clindamycin is typically given over 10 to 60 minutes every 8 hours, and vancomycin is infused over 1 to 2 hours and given every 8 to 12 hours, depending on the dose. With all of these antibiotics, if you experience stinging or irritation, you can always ask them to slow it down or to deliver more fluids along with the medication to kind of dilute the stinging effect. Now, some people are wondering, why do I have to have multiple doses? Why does it have to be repeated? That's because as long as you're in labor, the GBS suppressing effects will wear off over time. So they keep the medication going until the baby is born. Now, while the IV is running, it should not limit positioning, walking, or even laboring in water. They can kind of saran wrap your arms that you can get in a tub. And for the hours in between, which can be long in some cases, you can ask for the IV to be HEP locked or saline locked and detached so that you are free from the IV pole and tubing. And we have an article all about saline locks during labor and a podcast episode, and we'll link to that in the show notes. Another big question we get from people is about treatment or caring for newborns if you're GBS positive and you don't get the IV antibiotics for some reason, or maybe you only got it like a few minutes before the baby was born, so there's worries that the baby could still be exposed to GBS. So what kind of tests are needed? There's new guidelines from the American Academy of Pediatrics that talk in depth about the different strategies healthcare workers might use if your baby is born at 35 weeks or later. And the first strategy is called the risk assessment by categories. Now there's many different versions of this approach used around the world. But here's an example. If the birthing person is a GBS carrier and they received penicillin, ampicillin, or cefazolin for 4 hours or more before birth, then their baby is labeled as having, quote, adequate, end quote, early GBS disease prevention. On the other hand, if you are a GBS carrier and you received any other antibiotic, or the antibiotic was given less than 4 hours before birth, then your infant would be considered as having, quote, inadequate prevention, end quote, and they would recommend observation, maybe even drawing blood to test their blood, or antibiotics for the baby, depending on the category that the infant falls under. And one major drawback to this risk assessment by category approach is that it results in lots of interventions in many low-risk infants who are not sick and were not going to get sick. Another option is to use the neonatal early onset sepsis calculator. So this is where information about the birth, GBS status, and the infant's health condition are entered into an evidence-based calculator that was developed through large, high-quality research studies, and we did a training all about this for our EBB Pro members a couple of years ago. This calculator is really cool. It is freely available, and we will link to it in the show notes. It suggests different courses of action based on your infant's individual score. And one benefit of this calculator is that it determines the risk of the infant developing an infection, looking at all different kinds of infections, not just GBS. A third strategy that some healthcare workers will use is risk assessment based on the newborn's health condition. This is when infants who appear well at birth don't get any special tests or interventions, unless there was inadequate prevention of GBS or the birthing person had a fever during labor, in which case the infant would just be checked by a healthcare worker frequently over the next 36 to 48 hours. In contrast, infants that appear sick when they're born or develop signs and symptoms of sickness over the first 48 hours would have blood cultures drawn, and they'd be treated right away with antibiotics. Now, those are the pathways for infants born at 35 weeks and older. If an infant is born before 35 weeks and 0 days, they are at high risk of early infection from all causes, and the AAP recommends that healthcare providers base their management on the circumstances of the preterm birth. For example, management of the infant's care would differ depending on whether the preterm birth was caused by an infection or caused by preeclampsia. Some people also want to know, how do I know if my baby is sick? Like I talked about sick appearing versus healthy appearing infants. And obviously healthcare workers should be trained and know the signs of illness in infants, but it's also important for parents to educate themselves about normal newborn behavior and appearance, as well as the warning signs of illness so that they can advocate for their child. And I highly recommend the Association of Ontario Midwives website and handouts all about Group B Strep. They have a printer-friendly handout all about normal newborn behavior and warning signs of illness. You can access it at ontariomidwives.ca/GBS. And they recommend contacting your healthcare provider if your newborn infant has any signs of early GBS disease. And based on the American Academy of Pediatrics and the Association of Ontario Midwives, we did list some of these symptoms of GBS disease in our new article on Group B Strep. This was a new addition to the article I think is really important, but also you got to keep in mind this list is not exhaustive. There could be other symptoms as well. But I'm going to list the most common. These include a fast heart rate. For example, more than 160 beats per minute would be abnormal for a newborn. Fast breathing, for example, more than 60 breaths every minute, with the fast breathing lasting more than 10 minutes. The baby is lethargic and you cannot wake it to feed. The baby is limp or not interacting with the caregiver when awake. A fever of 38 degrees Celsius or higher, that's also 100.4 degrees Fahrenheit or higher. Poor feeding, irritability, high-pitched crying or crying all the time, grunting or their nasal flaring. The baby's skin pulls in sharply around the ribs or the base of throat when they're breathing in. Repeated projectile vomiting, temperature instability, bulging soft spots on the head, brick dust color in the baby's diaper more than 3 days after birth, no wet diaper in 24 hours, or any other worries about the baby's health. The Association of Ontario Midwives also recommends calling 911 and your provider if your baby's skin color changes to blue, gray, or pale. Although temporary blue hands or feet can be normal in the first few days of life, or call 911 if their breathing stops for more than 10 seconds. Lastly, before I get into the national guidelines, I want to talk about how GBS can affect different communities differently. Over the past few years, every time we update a signature article, we've attempted to incorporate inclusivity and any info on equity or health inequities and solutions that we think is important that our readers should know about. One of the things that I kept seeing over and over in the research is that researchers were reporting health disparities, with African American birthing people having higher rates of GBS positive tests and higher rates of GBS disease in their newborns. And the 2022 Clinical Practice Guidelines from the Association of Ontario Midwives reports that Black pregnant people may be more likely to convert from GBS negative to GBS positive due to systematic health disparities or inequitable delivery of antibiotics. But overall, the disparities with GBS in African Americans are not widely researched nor well understood. Now, ACOG, the American College of Obstetricians and Gynecology, lists quote, maternal Black race, end quote, among their list of risk factors for an infant to develop GBS disease. However, the Human Genome Project confirmed in 2003 that humans are 99.9% genetically identical, and there are often more biological differences found within people of a single race than found between people of different races. Geneticists have described that race is a social construct, not a scientific or genetic one, and it can be really challenging to determine what are the societal expectations of race and what that means for someone who has any kind of historically mixed ancestry. Experts in racial health disparities, such as Dr. Joya Creer-Perry, OBGYN and founder of the National Black Equity Collaborative, often clarify this situation with this explanation, quote, race isn't the risk factor, racism is, end quote. Research has found that as a result of racism, including racial weathering and chronic stress, Black, Brown, and Indigenous communities experience higher rates of hypertension and labor complications, preterm labor, cesareans, low birth weight babies, and lower rates of breastfeeding or chest feeding. More specific and more measurable than, quote, Black race, end quote. Some of these factors put infants at higher risk of developing GBS disease. And racial weathering also puts birthing people at risk of early cellular aging and a weakened immune system, making them vulnerable to both allergies and an imbalance in the microbiome of the gut. This puts them at higher risk of both being GBS positive and having a possible sensitivity or reaction to antibiotics used to treat GBS. Communities that experience discrimination in healthcare for any reason may also face real-time challenges from certain providers, whether the provider is aware of it or not, such as delays in care, less monitoring or less attentive monitoring, microaggressions, false beliefs about the patient, or unequal delivery of procedures and tests. Structural inequities might show up in low-resource areas of the world where health centers face shortages of IV antibiotics, chronic understaffing and overworked providers, poor basic infrastructure, or lack of access to laboratories for culture testing. All of these are systematic factors that can interrupt patient access to care. So for any birthing person who has multiple layers of risk factors, we need prevention and extra wraparound care and attentiveness, and this can be life-saving. Evidence-based preventive health options such as probiotic supplementation can be discussed early on when you're pregnant, and extended family doulas and community advocates can be trained on the signs and symptoms of GBS disease and infection in newborns. They should know how to use the neonatal early onset sepsis calculator to determine the likelihood of illness. And this can be a really helpful resource to support their case, especially if they feel a provider is not listening or acting urgently enough to treat their child. Parents and healthcare workers should also be aware that low oxygen can look different on darker skin. It can look more grayish or whitish rather than blue. And they should know that pulse oximeters are more likely to have inaccurate results in infants with darker skin tones. So sometimes you just need to trust your instincts rather than what the monitor is saying. So that answers some questions that we've received about GBS. Now let's talk briefly about what several national organizations have to say. In the United States, the U.S. Centers for Disease Control and Prevention, or the CDC, transferred stewardship of GBS prevention guidelines in 2018 to ACOG, to the American Academy of Pediatrics, or the AAP, and the American Society of Microbiology. The 2019 ACOG recommendations were reaffirmed in 2022 and also endorsed by the AAP. And they include a recommendation that all pregnant people should be tested for GBS between 36 weeks and 37 weeks. Everyone who is positive for GBS should have appropriate IV antibiotics during birth unless they are giving birth by pre-labor cesarean and the membranes have not yet ruptured. The antibiotic of choice is IV penicillin, and IV ampicillin is an appropriate alternative. For people with a reported allergy to penicillin, if they are at low risk for a severe reaction, then IV cefazolin is recommended. If somebody has an allergy to penicillin and they're at high risk for a severe reaction, then clindamycin should only be used if the culture testing shows that their GBS strain is susceptible to clindamycin. Testing for a penicillin allergy is also appropriate for people who have a history of penicillin allergy, as many people with childhood reactions will no longer be sensitive or allergic to penicillin later in life. If someone has a high-risk allergy to penicillin and their GBS strain is resistant to clindamycin, then IV vancomycin is the only other alternative, and you need to have strict weight-based dosing and safe medication delivery measures, which we detailed in part 1 of the series that should be followed. They also state that healthcare staff should not delay or withhold necessary medical interventions such as membrane sweeping, rupture of membranes, Pitocin, vaginal exams, or water immersion during labor, just because someone is GBS positive or because the healthcare worker wants to give the recommended 4 hours of IV antibiotics. I already mentioned the 2019 American Academy of Pediatric Guidelines, and we linked to those in our article. And there are also detailed laboratory testing guidelines from the American Society of Microbiology that we also linked to in the article. In the United Kingdom, the approach is very different. There, the UK National Screening Committee states that pregnant people in the UK should not be screened for GBS. Screening for GBS in pregnancy is not covered by the National Health Service. However, some people choose to be screened for GBS outside the NHS. In general, practitioners in the UK follow the other risk factor approach. This includes giving IV antibiotics to anybody in labor who has a fever, prolonged rupture of membranes more than 18 hours, GBS in the urine at any time in pregnancy, preterm labor, or giving birth to a prior infant with GBS. As a result, some people who would have tested negative for GBS do receive antibiotics targeted at GBS. And in the United Kingdom, the rate of early GBS infections is 0.53 per 1,000 births, which is higher than the rate of 0.2 per 1,000 births in the US. The Royal College of Obstetricians does not recommend routine screening for GBS during pregnancy. However, they do state that in-labor antibiotics could be considered if the birthing person sought GBS testing outside of the NHS and tested positive, or if the birthing person had any of the other risk factors that I just listed. But there's a lot of controversy in the United Kingdom over the lack of access to GBS testing within the National Health Service. Group B Strep Support is an independent charity that advocates for families to have access to GBS screening in the UK. So they offer a supportive telephone line, leaflets and publications, a private Facebook group, and links to order GBS tests online. In Canada, the Society of Obstetricians and Gynecologists of Canada recommends offering GBS screening to all pregnant people between 35 and 37 weeks, and they recommend providing those who test positive, as well as anyone with an infant who is previously infected or anyone who has a positive urine culture, to have the appropriate IV antibiotics during labor. The Association of Ontario Midwives recommends GBS screening and has many resources to help with evidence-based practice, including really thoroughly written guidelines based on the evidence, GBS app that midwives can use, sample protocols, and handouts for parents on GBS and pregnancy, and the one I talked about earlier, the handout on normal newborn behavior versus signs of illness. The Association of Ontario Midwives recommended in 2022 that midwives should offer all their clients screening for GBS at 35 to 37 weeks, and that clients can be instructed on how to do the swab themselves. They also recommend that midwives should discuss the benefits and risks of penicillin allergy testing with anybody who has an uncertain history of allergy, and they also recommend that midwives discuss the benefits and risks of 2 approaches. Number 1 being screening for GBS at 35 to 37 weeks and having IV antibiotics during labor, or the second approach would be screening for GBS at 35 to 37 weeks, but only having antibiotics in labor if an additional risk factor arises. That's kind of that combination approach I talked about towards the beginning of this podcast that unfortunately we don't have a lot of research on yet. So you made it all through episode 255, all about part 1 on GBS, and then today's episode all about alternatives and frequently asked questions. So now I'm excited to share with you our bottom line on GBS. The bottom line is that Group B Strep is a normal part of the microbiome bacteria for some pregnant people, but it can cause early GBS disease, which is a serious illness in a minority of newborns because of their immature immune system. Researchers have found that if you carry GBS and you're not treated with specific antibiotics during labor, then there's a 1 to 2% chance that your infant will develop early GBS disease. There has been a global debate as to whether we should focus on preventing early GBS disease or if we should focus on preventing the harms of antibiotics. In countries or places where preventing more cases of GBS is the priority, people are typically screened at 36 to 37 weeks, and then if positive, they're provided antibiotics during labor. If appropriate IV antibiotics are given 4 hours or more before birth, then the risk of a GBS carrier's baby experiencing early GBS disease goes down to about 0.2%. On the other hand, in places where preventing the harms of antibiotics is the priority, people are not screened for GBS during pregnancy, and they're only given antibiotics if other risk factors occur. Antibiotic usage, though, is going to be similar in places that use universal screening as it is to places that use the other risk factor approach. But overall rates of early GBS disease are higher with the other risk factor approach, 0.5 per 1,000 births versus 0.2 per 1,000 births. There is an excellent handout for informed consent that describes the benefits and risks of both of these approaches, available at the Association of Ontario Midwives website page on GBS. The universal screening approach is the most effective approach, but it is not perfect, and it will never be able to eliminate all cases of early GBS disease. Also, the universal screening approach is only available when you have easy access to laboratory testing and IV antibiotics. In low-resource places where there's no policy at all used to prevent GBS disease, they don't use the universal approach, they don't even use the other risk factor approach. In those places, GBS disease disparately causes serious newborn illnesses and deaths. Eventually, the most effective way of preventing GBS disease in infants would be access to a safe and effective vaccine against GBS during pregnancy. One GBS vaccine has found promising results in phase 2 testing. Unfortunately, the other alternatives to antibiotics have either not been shown to be effective against GBS disease or they've not yet been sufficiently studied. For example, the research does not support chlorhexidine or hibiclins wipes or topical use on the vagina. Topical insertion of garlic has not been studied in pregnant people. And because early onset GBS disease usually begins in utero, GBS gets access to the amniotic fluid and gets into the baby's lungs during labor. So it's really unlikely that topically applying something can prevent all cases of GBS disease in newborns. Regardless of what method of GBS prevention you decide to use, we think it's important that parents educate themselves on the warning signs of newborn sickness in case they need to seek urgent medical care. And again, we recommend the handout at the Association of Ontario Midwives. Overall, about 1/3 of people in high-resource countries are given IV antibiotics during birth. These antibiotics do have the temporary side effects of negatively impacting the infant microbiome. If you receive IV antibiotics, there might be an increased need for probiotic supplementation for your infant after birth if you cannot or choose not to feed your infant with human milk, if you gave birth by cesarean, if your baby was born prematurely or admitted to the NICU, if you had a high risk of penicillin allergy and received a broad-spectrum antibiotic such as clindamycin or vancomycin that has a stronger impact on the microbiome. On the other hand, parents who might have increased concern about GBS disease are those who have culture results that show they are a GBS carrier, preterm labor, prolonged rupture of membranes, a fever during labor, a history of urinary tract infections with GBS, or a previous infant who was diagnosed with GBS disease, or if you think you received improper culture testing at 36 to 37 weeks. Remember, the test is likely to be inaccurate if the Q-tip did not enter through the anal sphincter. In the end, we hope parents who face decisions around GBS testing and antibiotics feel encouraged and educated to have open conversations with their providers about the benefits and risks of their options. And the truth is there's no perfect decision for everyone because there are trade-offs to every decision and every family's situation is unique. So our hope is that with solid information and access to resources, that families will each have the power to make the decision that is best for their unique situation. That concludes part 2 of the evidence on GBS. I hope you enjoyed and found this episode useful. I do want to thank Ihotu Ali, MPH, and research editor at EBB, who helped review this article and also helped write the paragraphs about how GBS affects different communities differently. And I'd also like to thank my sister, Dr. Shannon Vogt, for peer reviewing every edition of this article since it's originally come out, as well as the original co-author who helped write the original 2014 article with me, Dr. Jessica Iluzzi. Next week, we're going to switch gears a bit and share a water birth story with one of the graduates from our EBB childbirth class and talk about a potential complication from water birth and how you can avoid or prevent that complication. I am really excited to share that story with you. And again, if you want more info on GBS, just go to ebbirth.com/Group B Strep to find the full article, the long list of peer-reviewed references, and the one-page free handout you can get to go with this podcast. Thanks, everyone. I'll see you next week. Bye. Today's podcast was brought to you by the signature articles at Evidence-Based Birth. Did you know that we have more than 20 peer-reviewed articles summarizing the evidence on childbirth topics available for free at evidencebasedbirth.com? It takes 6 to 9 months on average for our research team to write an article from start to finish, and we then make those articles freely available to the public on our blog. Check out our topics ranging from advanced maternal age to circumcision, due dates, big babies, Pitocin, vitamin K, and more. Our mission is to get research evidence on childbirth into the hands of families and communities around the world. Just go to evidencebasedbirth.com, click on blog, and click on the filter to look at just the EBB signature articles.